Assalamu alaikum. Welcome everyone on board. So we will continue our discussion from where we left yesterday. Zishan, what is infantile hypertrophic pyloric stenosis? Zishan, are you here?
Sir, it is a congenital disease in which there is a hypertrophy of pyloric part of a stomach in young infants, sir.
Okay. So what is the
Yes, sir,
result?
and which cause symptoms such as vomiting, projectile vomiting, and electrolyte abnormalities in the body, sir.
Okay. So like what is the sequence of events which occur? Like how this baby will be presented?
Sir, yes, sir. Basically, sir, due to the gastric outlet obstruction in the pylorus region, and
Okay.
so there is a when the infant cannot digest and there is a copious vomiting due to the outlet obstruction, and
Uh,
as there
uh,
is a vomiting outlet.
okay. Are you sure the word digestion is good?
Not digestion, sir. Normal peristaltic movement, sir. You can say that,
Peristaltic.
or
Mm,
normal uh,
like stomach, the door between the stomach and intestine is closed. Okay.
closed. Yes, sir.
So not or very, very limited. Okay. So
Yes,
nothing
sir.
is going down. So it is sort of intestinal obstruction, sort of thing, you can say. Okay. And
Yes.
everything in the stomach is not able to pass. So there is projectile vomiting. Okay.
Yes, sir.
Projectile vomiting. And when all the acid which is there in the stomach is going out. Okay. So what is happening? So there are
So
electrolyte
then there,
imbalance.
yes, sir, electrolyte imbalance.
So what electrolyte imbalance occur?
Sir, due to the loss of hydrogen ion, chloride ion,
हाँ
potassium ion, and
है
sodium ion, uh, so there is hypokalemic metabolic alkalosis, sir.
okay with so whenever there is hypovolemia, what is the response in the body?
Sir, the RAS is activated and body compensation mechanism activated, and so aldosterone is secreted, and
Okay,
body try to compensate for the dehydration in the body, sir.
okay,
So, so due to that, uh, the body tries to excrete uh, uh, potassium and hydrogen ion in the urine and conserve as much H2 as it can. So more hydrogen ion and potassium ion are lost in the urine to conserve water. So the urine become acidic, sir.
okay. So what is the name of this thing which occurs? Because loss of usually when there is loss of acid, the body should be conserving and there is alkalosis. So the body response is to should be to conserve the hydrogen. But here what is happening? Here opposite is occurring. Okay. So actually,
Yes.
so that is called as paradoxical aciduria. Okay. So instead of
Yes.
conserving the hydrogen ion, body is even releasing more hydrogen. Okay. So that is called as paradoxical acid urea. Okay. And
Okay.
why it occurs? Because significant critical hypokalemia is not compatible with life. So this is a body response to and to maintain the neutrality. They're trying to conserve potassium at the cost of releasing hydrogen. Okay. So what is the like anesthesia consideration? Is it a medical emergency or surgical emergency?
Sir, it is a
Medical.
medical emergency.
Yes. So we have to correct the electrolytes. Okay. Correct the volume status
Sir.
and
And
the baby start pee, urine output starts,
the
chloride is,
patient should be resuscitated.
yes. So it is hypochloremic, hypokalemic, hyponatremic, metabolic alkalosis with paradoxical acid urea. Okay, this is the sequence of events what occurs. And because as we know that clinical parameters or response of dehydration will not be there, so you will be looking at the physical like mucous membranes, fontanelle, skin turgor. So these are the physical signs. There will be no urine output. These will be the things which will be there. So you have to start resuscitation with isotonic fluids. And once the baby is resuscitated, then you will proceed with the surgery. Okay, and before that there is something which you have to do because that patient is risk of aspiration. So there is a concept which you will see in the tutorial. It's written four quadrant suctioning. You will put NG and you will rotate the baby. I don't know how to do it, but remember this thing that you have to careful. If you forget this four quadrant suctioning, so maybe you can don't forget to tell suction, and then you can say, because now it's era of ultrasound, so you can still say that you have to identify the residual volume in the stomach. Okay, so for example, if they try to operate before it, so what will happen? So if you don't optimize the patient and you take the patient for surgery, so what will be the problem which can occur? So there may be prolonged ventilation. Okay, because of electrolyte imbalance, especially which, Fatima, can you tell which electrolyte will be responsible for delayed emergence? Like if you identify potassium, hydrogen, sodium, potassium, magnesium, which will be the electrolyte which will be mainly responsible for delayed emergence?
Sodium, sir.
Very good. Okay. So sodium, because it is the one which is creating the the balance in the cerebrum, in the brain. If there is
Yes,
a
sir.
disorder of sodium, then there is maybe cerebral edema, and it will because there is will be hyponatremia, so it can cause cerebral edema. More water will go inside the cell. Okay, so this is an important topic which you should be knowing. So next, have what is congenital diaphragmatic hernia? Zishan, is your connection not good? Any other exam candidate other than Fatima? Fatima, you want to speak out? What is congenital diaphragmatic hernia?
Sir, yes, sir. Your voice was not coming to us. Maybe there is some connection problem from your
Just a
side.
second. Just a second.
Acha.
I will just reconnect. Okay, so am I audible now? Am I audible now? What did okay, okay. So what is congenital diaphragmatic hernia? Actually, very simply, what is the basic problem is that there is diaphragmatic like orifices through which developmentally things are coming out or going out. Okay, so they fail to go to the towards the abdomen. So the intestines and everything is there inside the chest. So what is happening, that lungs, which they are not able to grow properly. So actually, there is a problem of even the diagnosis, maybe that in the chest X-ray, The abdomen is scaphoid, abdomen is inside, and all the intestines you are seeing in the chest. Okay, so mainly the what is the problem here? A number of times the baby will be premature. There will be associated congenital anomalies, and there will be mainly problem with the lung maturation. So airway resistance will be more, and compliance will be less. And if you try to ventilate hardly, there may be development of pneumothorax. Okay, so a number of time the main management is to achieve the development of lungs. Okay, so maybe such babies, if they are born prematurely, a number of time they remain in ICU for some time. Even they remain on ECMO. They have the like they let the growth of lungs a little bit, and then they proceed uh, with the with the surgery. So again, this is also a medical emergency, not surgical emergency. Okay, so you will be asked about like how to evaluate a patient with the congenital diaphragmatic hernia. Okay, they will be asking the name of the diaphragmatic opening. I think Morgagni. I forget the names. You will find here. So, does anyone remember the name? You will find somewhere. Anyways, because this is not very important, and they can ask you, but this is not the failure point. Just a second. There will be anatomy here. We will see here. Okay. So defect is this Morgagni and Bosch-Delic. Okay, so this is one thing. And then, as I told you, there is pulmonary hypoplasia and pulmonary hypertension. So this is another thing. So they maybe remain on ECMO, as I told you. They are receiving sildenafil or some things to reduce the pulmonary hypertension. Okay, and once uh, like the lungs are getting the maturity, the things are getting better, then they will go for the surgery. Okay, so okay. So as these patients, you concerns which will be there will be related to prematurity. Again, other congenital anomalies. Okay. Um, and so okay. So this was so immediate intubation, pre and post ductal saturation. Can someone tell me what is the concept of this pre-ductal, post-ductal? Yes, Fatima. Actually, the right brachiocephalic trunk comes out before the origin of this PDA, which is patent. And actually, in such patients, if in which there is pulmonary hypertension, and for example, there is this patent ductus arteriosus, and the accurate saturation is coming from this right radial artery. So that is important to monitor, because if there is right to left shunt after the ductus arteriosus, that saturation is not reliable. Okay, so this is something which you should be knowing. So okay, so another question which you should be knowing, that how will you anesthetize a patient with congenital diaphragmatic hernia, because the problems will be related to ventilation. Okay, you are not able to ventilate nicely. Fatima, are you listening? Yes, Zishan, are you
Yes,
here again?
yes,
Yes, yes.
mm,
So,
yes.
you know, so how to intubate a patient with congenital diaphragmatic hernia?
Sir, inhalational or spontaneous ventilation?
Yes,
We don't
because
have
if
to give.
positive pressure ventilation, okay? Because if
Yes,
you
sir.
are
Positive
giving
pressure.
positive
No bag
pressure,
mask
hmm
or no positive
Or
pressure
else
ventilation.
So what? Okay. So
Inhalation, go for
yes, yes.
inhalational and spontaneous ventilation, and have a low tidal volume,
Hmm.
permissive
और ऐसा
hypercapnia.
Yes. Permissive. What do you mean by pervasive hypercapnia?
So we can carbon dioxide can be at the upper level of 45
Hmm.
mm
What?
mercury allowable.
Millimeter.
So because when we ventilate mercury,
Okay.
so 4.5 kPa, मतलब kilopascal or mercury or
Yes.
45. Am I right,
Yes.
sir?
Yes, yes, you're right.
Yes.
Actually, the concept is that you will not try to overventilate. Okay. Like
Yes, sir.
it's not like that you want hypercapnia. It means that if you are not able to achieve the target, like you increase the pressures and still you are not able to ventilate, you will not try to overinflate. Even if you are able to achieve and somewhat good oxygen saturation, you will not overinflate. That's the concept. Okay. So
Yes,
you
sir.
that it's not like that you would like to have hypercapnia. Okay, so that is, I hope you
Okay,
understand.
sir.
So
Yes,
the
sir.
because the determining factor will be that you will not create too much airway pressures, so that and actually they in the troubleshooting they will ask that during the surgery patient develop hypoxia and you auscultate and there is no breath sound on one side. So what has happened?
Pneumothorax on the
Pneumothorax.
contralateral side of the side where there is hernia and
Yes.
hypoplastic lung, the other side will develop the pneumothorax.
Like try to be simple, there is pneumothorax, so they have to
Okay.
they have to put
Pneumothorax.
the chest tube. Okay, surgeons will put
Yes, sir.
the chest tube to inflate the lungs again. Okay, so that is these are because actually this is the topic of pediatric anesthesia. This is, you can say, subspecialty. Okay,
Yes, sir.
so but usually these are the thing which you should be knowing and you should be considering. Okay. Mm,
Yes, sir.
okay, so another question, what is ECMO? You should have few words about ECMO, that it is extracorporeal membrane oxygenation, and it is like, you can say, bypass, but it the heart function is there. You are only achieving the lung oxygenation. So difference between bypass and bypass machine oxygenation and pumping, both are there. And here actually they are doing, it's again you have to do the heparinization of the system and everything. Okay, so this is the last resort, because as it's also mentioned here about the high frequency ventilation, so they are also doing some high frequency ventilation. Okay, so you see here, uh, in case of high FiO2 requirements, pre to post ductal difference more than 10%, or in cases of hypercapnia with high PIP. Okay. Just tell me one thing. What will be the effects of high FiO2 in this patients, Fatima?
Sir, high FiO2 oxygen is
Okay, Zishan, have you
sir,
heard of
can you repeat, sir?
actually if it is you are giving too much FiO2 in these babies with congenital diaphragmatic hernia, what are the problems you can have? What is ROP?
retinopathy of prematurity. But sir, I have a question.
Yes.
Because FiO2, I mean that 100% FiO2 when given for a more time, then retinopathy of prematurity develop.
Yes, but
Or I mention it.
higher FiO2. So if you read about it, and it's not like that
Yes,
whenever
sir.
you will give 100% oxygen or high FiO2, it will develop. It is like it can occur without in premature babies, it can occur even without it. Okay. So if you are
Yes.
giving relatively higher FiO2, the chances of development will be more. Okay. And actually retinopathy is
Yes.
like new
Yes,
vascularization,
sir.
and also
Sir,
there
is
are
oxygen toxic to some lungs in
ox
babies?
yes. What is the name of that toxicity?
Sir, I don't remember it, but I was recalling it.
Respiratory distress syndrome. Okay. This is also because
Yes.
of oxygen free radicals. Okay. Actually,
Yes,
remember
sir.
one thing. The good thing
Yes,
about
sir.
this topic is that even examiner will not be knowing too much. Okay. So they will not
Okay.
they are not expecting too much from you. I'm just to make you relax because this is a complicated topic. So if you just recall what you
Yes,
need
sir.
to know, you will say that all the concerns in a neonate. If the baby is premature, concerns related to prematurity. Okay. These two things you can tell.
Yes, sir.
And then basically you just explain what is congenital diaphragmatic hernia. The abdominal contents which are supposed to be in the abdomen, and they are in the lungs. So whatever in the lungs is in trouble. Oh, sorry, what is in the thorax is in trouble. So that's very simple. So when lungs are not mature, there is problem in ventilation, pulmonary hypertension, okay, and chances of pneumothorax. When you are ventilating the such patient, avoid high airway pressure. We try to be very simple. Rest of the things are the same. Same hypothermia, same problem in IV lines, same problem of if the baby is premature, another problem related to anesthesia is related to central apnea. Okay. So post-operative apnea can occur in any premature baby, and you have to calculate the post-gestational age. You know how to calculate post-gestational age? With reference to, we will just have a look on the prematurity topic as well. So there are certain things which are important in premature babies. So one of them is post gestational age. Okay. So the birth age, like for example, 28 weeks the baby is born, and now the baby is 7 months. So now the post gestational age is 56 weeks. You got it?
Yes, sir.
Okay. The baby was born at 28 weeks. Okay. And now the baby is 7 months. So 7 month means 28 plus, or I'm sorry, 7 multiplied by 4. So 28. Okay. So it is 56. If I'm not wrong in my calculation. So now it is 56. Okay. And some books will say 50 and some books are saying 60. So 50 to 60 weeks, there are chances of. So there is apnea alarm, apnea monitoring you have to do. Okay. So just I have tried to tell you the important points, and if they will you should be knowing the concept of this pre-ductal and post-ductal. And if the difference is too much, it means there is significant right to left shunt. So you have to take arterial line in both sides, okay, right radial arterial line, and you have to compare it with the other side. The on same things are written. Don't be afraid from this terrible chart. You don't need to remember each and everything, okay. And the rest of the things are the same as I told you. See, steroid, sildenafil. If the patient is not maintaining the saturation or maintaining the vitals, you have to give, because you have to maintain. How will you maintain? What is Eisenmenger phenomena? What is Eisenmenger phenomena?
Sir, in this case, patient have a abnormal opening between the right and left. So first, the left pressure of the hearts are high. So there is from left to right shunt.
Okay.
With passage of age or with passage of time, the right side of the heart developed the pressure which becomes higher than the left, and then pulmonary due to pulmonary hypertension also develop, and then flow came from left to right, shifted to right to left shunt.
Yes. Actually, you have explained in detail, but actually, very simply, it is the reversal of the shunt. Okay. So
Reversal.
Eisenmenger phenomena
Okay,
is a
thank you, sir.
reversible. Maybe sometime it will be irreversible, but sometime it is reversible. Like any condition in which SVR is decreased and PVR is increased, so it will lead to, whenever the door is open, there may be smuggling going on. Okay. So you have to maintain the PVR. That is the same concept which we do in Fallott's tetralogy, where they say to do squatting. When the baby squat, actually it is increasing the systemic vascular resistance. Okay, so the right to left shunt is decreased. So the same is the true here. By giving vasopressors, they are trying to increase the pulmonary vascular resistance so that the shunt is reversed. And sildenafil is to reduce the pulmonary vascular resistance. Another medication which is being used as an inhalational agent for as a therapy, inhalational therapy to reduce the pulmonary pressure is, what is the name of that thing?
Nitric,
Nitric
nitric
oxide,
oxide,
not nitrous. Okay, nitric oxide. Okay,
nitric.
so and the formula the unit is particle per million, something like that, ppm. Okay, so on, these are maximum you should be knowing, and this time 5 minutes will finish. Okay, so answering a congenital anomaly is sometimes very easy. Okay, so these same things they have written here. You see, right to left shunting, and if you will read, they will find the same thing as pulmonary vasodilator, mitigating the factors which are increasing the pulmonary vascular tone. Okay, so hypoxia, hypercarbia, pain, mechanical compression of air in the stomach, and these other things. You don't have to reproduce each and every line from anything. You just have to scan and you have to pull out the things which are important to you. Okay. So uh, such charts will give you help. That like in this chart they are telling temperature investigation that determine fitness of surgical repair of congenital CDH. So you can, if you remember this thing, like you are telling that patient is now hemodynamically stable. Same they are writing in this thing. What is it? Saturation is good, minimum FiO2. Okay. Mean arterial pressure is good for that gestational age. Inotropes are minimized or weaning. Okay. Lactate, if lactate is more, it means there is anaerobic circulation. Okay. So urine output is good, it means the patient is not dehydrated. Okay. So and then echo within 24 hours with good right ventricular function. Okay. For improvement of right ventricular function, there is a medication which is not, I think, not freely available in Pakistan. Luckily, I have honors to work 2 year in cardiac anesthesia. So that's why I know these things a little bit, not much, but a little bit. Way back about 12 years ago, I worked. So the one of the medication to improve the right ventricular function is milrinone. Okay. What is milrinone? Do you remember?
The prostaglandin PGI2, I maybe.
No, phosphodiesterase inhibitor. It's like
Okay, sir. Phosphodiesterase.
just reconfirm. Just reconfirm. Even maybe I'm not faltering. Okay. Just recheck. So this is
Yes, yes,
how
yes.
this
I will.
you can recall this chart and then you can speak out. Okay. Mm, this is how. Okay. So these are important points. These were you were telling. Lung protective ventilation via pressure control ventilation, low PEEP, target control of PaCO2, tight control of PaCO2. Okay. Okay. So what is uh, tracheoesophageal fistula? Then that, like it's a communication between trachea and esophagus. Okay. There will be various type of it is in so, but the common one is the one in which there is I think distal atresia with the proximal fistula. I think this is the one which is, I think this is the one which is more common. Okay, proximal atresia and distal communication. If I'm not wrong, this is the most common. C. Okay, they have written here. So you don't need to tell C. Okay, this is a mistake which you can do. You can tell that it is type C, but actually you have to tell that it is proximal atresia with distal tracheoesophageal fistula. Okay. In this, there is both atresia. And here there is proximal and distal atresia. Okay. Here both sides are joined. So here there is like that. So you just should be knowing what is different type. And again, the question will be the same, that there are chances of you should be knowing this vector and lateral. Okay. So this abbreviation, that vertebral anomalies, imperforate anus, cardiac defects, tracheoesophageal fistula, renal agenesis, limb abnormalities. Okay. So if they will ask you how to evaluate, so you can just tell, because it is associated with other congenital anomalies, and a group of anomalies, one or more can occur together. Okay. So you just need to tell the name of anomalies, and then you will, certain things will be through physical examination, and certain things will be through ultrasound, X-ray, echo. These things you will be telling. And again, it's again the same thing. Again, this is not a surgical emergency. Again, you will have to optimize the patient, and then you have to do it. They will ask you these sort of questions, that how to diagnose, and prenatal diagnosis, so these are not the failing points. The failing points is your basic anesthesia, sorry, basic understanding of the topic. Because again, I told you that this is actually subspecialty topic. Just like cardiac anesthesia, pediatric anesthesia is also a subspecialty topic. So if you will try to know each and everything, maybe you will not be able to understand the topic. So you should be very careful, sorry, very meticulous to understand what is the basic problem in that topic, and in that disease, and try to gather the basic knowledge. Okay. Like in this topic, they will ask you this question, how to intubate. Okay. So Fatima, can you tell how to intubate this patient?
Sir, I just remember it that it's the same as congenital diaphragmatic hernia. We don't have to go for the bag mask.
Okay.
No, I will be unable to pass the NG. I will go for the inhalational
Hmm.
and spontaneous breathing,
Hmm.
rapid sequence induction with suxamethonium and IV propofol.
Now you
If
see,
I not
listen.
go for inhalational.
Up till now, you were telling the right thing, but now you have slipped out of the track. Suxamethonium, you are saying on one side that you will not give, you will not make the patient mechanically
Yes, sir.
ventilated.
We will
So you know
go for spontaneous ventilation.
this is a suicide. Okay.
Yes, sir.
So
Get
remember
it,
one thing,
sir.
suxamethonium is a terrible medication in majority of cases. Okay. So unless
Yes,
even in the exam, if you want to do the rapid sequence induction, you can still say that if there is availability, not for this answer, not for this topic, but usually you can say that if it
yes,
is
sir.
available, rocuronium with sugammadex, modified rapid sequence induction is a better choice as compared to suxamethonium, because there are so many side effects of suxamethonium. Okay. So this is, so here, don't
Yes,
tell like this. So the important point is that according to the type, but usually you will do endobronchial first, and there are so many options. You can do it with fiber optic, or you can
yes,
have auscultation, constant auscultation, and
yes, sir.
two
Then I will
stethoscope.
draw back the. Yes, sir.
One stethoscope
I
will be in
remember.
the stomach, and you will also auscultate. When you will listen the gurgling sound in the stomach, it means you are at the play at the site of fistula. Okay. You will
Yes, sir.
come back a little bit, and then the gurgling sound will continue. You will just push the tube a little more, and then you will you will pass the at the point of the fistula. I will repeat.
Fistula. Yes, sir.
Yes, you will go endobronchial. You will gradually withdraw till the time you feel the gurgling sound in the stomach. That is the place where is the fistula. You will push the tube further in a little bit, maybe half centimeter, or less than half centimeter. Okay. So it means you will pass through it. So this is one thing, or fiber optic. You can intubate, and then you can confirm the position through fiber optic. Okay. So this is very simple answer. Any any concerns or any management related to general pediatric concern, or general neonate care, or general premature will be there. So if you are very good in telling about consent issue, IV line, hypothermia prevention, and meticulous control, titrated calculation of doses, problems in the liver, problems in the kidney, problems of the fluid, everything that's the same. If they want to, you can tell one by one, okay? But try to tell the main points about that topic, and then it will be easy, okay? So usually, like these are the things which you should be knowing. Again, you will use this word in addition to standard 1 and standard 2 monitoring. I will be monitoring this. I will be following this. So this will be the extra thing which you will be doing. Like urine output is also extra monitoring. If you are monitoring the cardiac output through arterial line, that is another monitoring. If you are monitoring, for example, muscle relaxant, then not for this is extra monitoring. If you are doing neuro monitoring, this is also extra. So you always remember to use this word. In addition to standard monitoring, standard 1 and standard 2, I will be monitoring this thing. So according to any case, you can speak out the extra monitoring you are doing. Okay. So like you see, this is what they have written. Fiber optic is available, and placement fiber optic can be used properly. Position endotracheal tube. Okay, crania is identified, because you will say that it will be, you have to carefully understanding what is the type. You will discuss with the surgeon what is the exact type of and what they want. Okay, so I think the same thing they have written here. Chest X-ray, ultrasound, gastrostomy is present bubbling versus lack of bubbling when the tube is above. So you just read it, the basic thing I have told you. Okay. And post-operative care, I don't think so. There is anything infants with the nasopharyngeal catheter used for suctioning. Yes. So because you will keep an NG tube. Okay. Even if it is not passing through it, you will do the suctioning through it. And these patients will have chances of pneumonia, ventilator associated pneumonia, or even aspiration pneumonitis. So but once you have repaired it, another important question, yes, preferably you would like to mechanically ventilate the baby post-operatively, or you would like to extubate.
So mostly these patients are post-operatively ventilated
It's opposite.
because
No, 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 no. Preferably, if you are able to extubate, that is better. Okay, because mechanical ventilation will lead to more trauma. There is more chances of uh, patient ventilator stacking. This is the again ghalatul am. Okay, this is again a mistake which we always do. It is always better to
I think
extubate
it's
and
written in the Oxford. I will confirm it.
confirm it. Okay,
Yes, sir.
so or okay, have a midway. At the end of the surgery, you will discuss with the surgeon what is their plan.
ठीक है sir.
If they are happy with the anastomosis, so we can give a trial. If you are keeping the patient
Yes, sir.
ventilated, there are chances of ventilator stacking and there may be anastomotic leak. Okay. If you extubate, if
Yes.
there is some residual, maybe respiratory compromise can occur. Is it now better? It's a diplomatic answer.
Okay,
Okay.
sir.
Now you
Yes,
understand
sir.
how, you have to convince the examiner that you know. Okay. So
Yes, sir.
you have to behave like a bloody politician. You like, I suddenly, when you are not happy, I suddenly change my answer. Okay.
Yes, sir.
So in the exam, also try not to give the blanket answer. Blanket answer means you are saying I will extubate, and blanket answer is that I will not extubate. So both of us had wrong answers. Your answer may be better, and my answer may be better. So now we have found a in between way. Okay, because there is no clear cut answer. So always use this. You will evaluate the patient. You will see the post of the course. If the extubation criteria is fulfilled, it's better to extubate because it will avoid some of the surgical complication. But you have to decide accordingly. Okay, according to the repair which has been done. Just a second, please. Okay. So, okay. So what are, so actually these are certain thing, the Down syndrome we had discussed yesterday. So one more I will do here today, that is abdominal wall defects. What is this one? Gastrochisis and omphalocele. What's the problem in it? If like abdominal wall is not properly made, okay, so the viscera may be out, okay. Something is that they are only, there is small defect, and something if it is totally agenesis and like viscera are outside abdomen. So there will be chances of injury, there will be chances of dehydration. So this is the basic concept. One is omphalocele, and one is gastrochisis. Okay. So if I'm not wrong, gastrochisis is usually isolated, and omphalocele is with other congenital anomalies. If I'm not wrong, just reconfirm, because they are identified through ultrasound. Okay. And you see the same thing. Phallocele occur when the intestine fails to return to the abdominal cavity. It is postulated that this is due to delayed closure of lateral folds. This is abdomen. This one I just want to reconfirm, uh, because one of them is isolated commonly, and one of them is uh, together with the other congenital anomalies. Okay. One is midline and one is lateral. So these are few things, and the rest of the things are the same. Same fluid resuscitation, care of, you see, herniated bowel or their blood supply, bowel decompression using nasogastric tube, and temperature regulation. Again, it's a this is a medical emergency. You have to optimize the patient and then you will go, unless as they have written, unless it is ruptured. Okay. Okay. So okay. So I think okay, my dear. So thank you very much. I will stop here, and inshallah, we will try to cover some more topics tomorrow, inshallah. Okay. So please read, because pediatric one scenario will definitely uh, come in your exam. As I tell you that usually in the table viva or even long case, you can say that majority questions are scenario based. Okay. So scenario based questions are main target you should be doing. And if you are able to, because around, I think if there are 20 scenarios, as 20 questions asked in the table viva, I think around 15, 14, 15 questions will be scenario based. And rest of the 4 or 5 questions will be direct questions about, for example, any condition or any team or any like anything. So focus more on scenario based questions. Okay. So Zishan, I think your internet connection was not working. You were not here. Bilal, are you available to speak out something? We discussed a few words about CDH, and this trichoesophageal fistula, infantile hypertrophic pyloric stenosis, and few words about it. So I think Bilal is busy. So okay, thank you very much, and inshallah we will continue tomorrow. Bye bye.
Thank you.